Hi. In this narration, we are going to talk about pain, temperature, and sleep. So some of our neurosensory systems, and talk about disorders that are correlated with these. So first up, let's talk about pain. So pain is unpleasant, obviously. However, it's a protective piece it's built into our bodies. It's instinctual, and we have it to protect us because if something causes us pain, then it's our body's way of telling us to stop. Okay, whatever it is we're doing. Pain is very individual. It's subjective. It can't be defined or measured by someone else, only by you. McCaffrey is a famous pain researcher, and she said that pain is whatever the experiencing person says it is, existing whenever he says it does. So it's not for us to judge whether or not somebody's in pain, regardless of whether they don't seem to be showing what we would consider signs of pain. So when we talk about how pain happens, there's a couple of terms. First off, nociception. Nociception is the perception of pain, and then it's regulated by our nociceptors. So these are nerve endings, and they're everywhere, right? They're in their skin, the muscles, the joints, your arteries, in your organs, in the linings of the abdominal cavity, and all of these nociceptors respond to different stimuli. Now, those stimuli might be chemical, they might be mechanical, they might be thermal. But all of those kinds of stimuli can cause you to have pain because the nociceptors feel that. So, for example, chemical stimuli would be something like a chemical burn. It's not really hot, it's not a thermal stimulus, like if you burn your hand on a curling iron or a hot oven, okay? So if you touch the stove or something, okay? So those are thermal stimuli. Mechanical stimuli would be you're hammering a nail and you accidentally hammer your thumb. Our nociceptors can detect all of these stimuli, okay? And so our nociceptors are super important, and they generally tell us where the stimulus is coming from, but not always. And so we'll talk about that as well. All right, so transduction is when the nociceptors are activated, and then transmission is the conduction to the dorsal horn and up the spinal cord. So remember that in this diagram here, it's showing the transmission of pain, right? So it's showing here's your pain stimulus right here. So now we have transduction, and then we have transmission up the spinal cord and then up to our brain, which helps us perceive it, okay? There's lots of different things that facilitate our pain sensation. Substance P, the purpose of that is pain. Prostaglandins cause pain. Bradykinin cause pain. And it also helps with our reflexive process. For example, if you touch something, your reflex, your reflexive action is to pull away from it. Okay? Now, the perception of pain, there's a lot of different things that are playing into it, okay? So the sensory discriminative system, that particular dimension of pain is basically how intense the pain is, okay? So where does it hurt? How long has it hurt? And so how intense is it? Now, the motivational affective dimension is more the unpleasantness of the pain. And that's how bad, that's how unpleasant it is, how it makes you feel. That's the part that wants you to avoid having that particular stimulus sometimes. Now, the cognitive evaluative system that means that our feelings toward the pain are influenced by previous experience, previous knowledge. Okay, that includes our emotional responses. Okay, and because it plays in and it interacts with that motivational and affective system, because our previous experiences are going to be what determines how we react to this pain. So all of them play into your perception, your overall perception of pain. Now, modulation is either facilitation or inhibition of the transmission of pain, okay? And so we're going to talk about different things that can affect that when we talk about neuromodulators. All right, so when we're talking about pain, few more terms here: pain threshold, perceptual dominance, and pain tolerance. So pain threshold is the point at which you no longer perceive something as just a touch, but rather pain. You no longer consider it warm, but actually painfully hot. Okay, so that's the threshold, and that's going to differ from person to person. Perceptual dominance is that my sister and I kind of laugh about this one. That basically says if you're experiencing pain in one spot, and then you experience pain in another spot, that other spot can make that first spot disappear. So, as an example, you have a headache, and all you can think about is your headache. And then you kick something like an air conditioner and you break your toe. You don't care about your headache anymore. Okay, that's perceptual dominance. My sister and I talk about it as if you are in pain, you have to transfer the pain. And so you hit something else. Okay, and that hitting something else makes that hurt. So let's say that you stub your toe, okay, and then you hit the wall, and the pain in your hand from hitting the wall makes you forget about your toe, okay? So we call it transferring the pain. What it really is perceptual dominance. Pain tolerance is how long you can put up with pain without saying, okay, I gotta do something about this, okay? And so your pain tolerance is also very subjective. Everybody's going to have a different pain tolerance. I do not have a very high pain tolerance. My mom did. My mom had a tremendously high pain tolerance. So it's really dependent on the person. All right, so our neuromodulators. So remember that this is what I said changes our pain, right? It increases or decreases our perception of pain, and they can happen at any time. Okay, because they're part of our nervous system. And our neuromodulators are triggered by the injury into the tissues or inflammation. And our neuromodulators are both excitatory and inhibitory. The excitatory neurotransmitters increase the perception of pain, and inhibitory neurotransmitters decrease the perception of pain. So our excitatory includes substance P, which we talked about already, glutamate, calcitonin. Inhibitory includes GABA, glycine, serotonin, and norepinephrine. So the norepinephrine being inhibitory is really important because during a fight or flight response, when you have norepinephrine running through your system, you don't experience any pain. And that's part of the fight or flight response is that you are able to run and you are able to flee or to fight without experiencing the pain that would make you stop and potentially cause you to be in danger, okay? Serotonin, we know, is an inhibitory neurotransmitter, and one of the ways that we utilize that is if people have chronic pain, a lot of them are going to be on medications that increase their serotonin levels, and so we'll learn about those when we talk about neuropharm. All right. Endogenous opioids are another kind of neurotransmitter that modulates pain, and these are actually very similar to morphine. They bind with our opioid receptors and inhibit pain impulses, and we have these throughout the body, okay? And so when we talk about our endogenous opioids, these are in your body, okay? We call them enkephalins. And they include endorphins, which I know you know what endorphins are. We also have dynorphins, endomorphins. Everybody knows what endorphins are, right? Endorphins are what give you the runner's high when you're running, and then all of a sudden you don't feel tired and pain anymore. I've never experienced that. But anyway, these particular natural opioids that we have in our body, they work really similar to morphine. And then they bind to our opioid receptors and we don't feel pain anymore. It's not a medication. Endocannabinoids, these are interesting. The endocannabinoid system, it's actually a system that we have, okay? And we have endogenous cannabinoids, and they are neurotransmitters that bind to our cannabinoid receptors. Now, we have these receptors everywhere. And there are a couple of there's a couple different ones. You don't need to know the names of them or anything, but our body synthesizes them from phospholipids. And this is a huge system within our body, and we're just now kind of realizing what it does. But it helps regulate everything from sleep to appetite, inflammation, memory, mood. And this is the system that marijuana hits. Okay. And so when we have cannabis, whether we smoke it or eat it, it actually produces a cannabinoid that attaches itself to this system. Now, this works then to relieve pain. Problem is, it has some psychoactive effects and it has some addictive properties. Okay, but this is the system that we're involved in when we talk about cannabis and THC. All right, so pathways of modulation. How do we change our pain? Okay, so first off, there's the descending inhibitory or facilitatory pathways. Okay, so these either inhibit or facilitate pain by activating opioid receptors. So our inhibitory pathways inhibit the release of excitatory neurotransmitters, and then they release or stimulate inhibitory neurotransmitters. The facilitatory pathway does exactly the opposite. Okay. Diffuse noxious inhibitory control. This is when two different stimuli occur at the same time from different sites. This is that whole transfer the pain again. Okay, so DNIC refers to the mechanism by which the neurons that are responsive to stimulation from one location may actually be inhibited by another stimuli, another painful, noxious stimuli applied to another location. Okay, so that we call them noxious stimuli. Now, the placebo effect. We know that cognitive expectations can cause physiologic effects. If you think you got pain medicine, then you will have a physiologic change. We know that this happens. We know that the placebo effect occurs. And it has to do with that cognitive and affective, those two discriminatory systems, when we're talking about modulation of pain. All right, so acute pain is a protective mechanism. It tells you that you are doing something that is harmful, okay, and you need to stop. So it's transient, comes and goes. It begins suddenly, and then once we remove the pain stimulus, it goes away. Now, we may have caused an injury that will then continue to hurt, okay? But depending on if we didn't cause an injury, then it shouldn't hurt anymore. So we've got a few types of acute pain. So first off, we have acute somatic pain. And these come from our A delta fibers and our C fibers. And they arise, so these are our nociceptors that are affected here, and they come from the skin, the joints, and the muscles. A delta fibers, your pain is very sharp, very well localized. You know exactly where it's coming from. Okay. C fibers are more poorly localized. It's a dull, it's a pain, an achy kind of pain. You can't really point to a particular spot, and say this hurts, okay? Now, visceral pain, acute visceral pain, is pain in your internal organs and in the lining of your body cavity. So specifically like your abdominal cavity, okay, your peritoneal cavity. The acute visceral pain is transmitted by C fibers. Okay. And so it's very poorly localized. You get a really, you might get a throb, an ache, cramping pain, just this overall where you're like, my stomach hurts. Well, where? Well, there's not really a spot. Okay. And so sometimes this pain radiates and then sometimes it is referred. So referred pain, and actually on the next slide, I have some examples of where you feel referred pain. Referred pain is present in an area that is not really what hurts, okay? So, like, we'll feel gallbladder pain. And remember, your gallbladder is like, where your gallbladder is on your, in your stomach, in your abdomen. We'll feel that in our shoulder. Okay, well, you don't have a gallbladder in your shoulder, but that's referred pain. Now, radiation is where it starts in one spot but tends to go down, so you can feel how the pain extends. Radiation is often a symptom of cardiac ischemia. So when they have chest pain that radiates down to the left arm. This diagram here shows you where you feel referred pain. Okay, so here, the heart pain you can see going down the arm. You can see the liver is all the way up in the shoulder here. They don't have the gallbladder on this picture, but you can feel all sorts of different things. Your bladder pain you can feel in your legs. Okay, all of these are examples of referred pain. Okay, and you don't have to know those locations, but understand the concept. Now, chronic pain is generally defined as pain that has lasted at least 3 to 6 months, okay? And it can be a constant pain. It can be something intermittent. It sometimes can happen very suddenly, where the pain starts very suddenly and then stays at that, intensity. Low back pain is often like that, where you get this really bad back pain and it just never goes away. Okay, so chronic low back pain is a huge issue. Or you can start to hurt and you don't even realize that it's, at some point you're like, man, my knee hurts. And you're like, well, I don't remember doing anything. And then day after day, it just gets a little worse, a little worse, a little worse. And you really can't pinpoint a cause. Okay. And so that's chronic pain. The way you respond to pain, to chronic pain, varies a lot. It causes emotional issues. It causes behavior changes, cognitive changes. And this is where your pain tolerance comes into play. We have a lot of issues that are associated with chronic pain. Now, one of the things here with this last bullet here, we don't see the physiologic signs. For example, when we have acute pain, let's say that I cut off my arm, okay? It hurts, right? My blood pressure, my heart rate goes up, my blood pressure probably goes up until I lose all the blood and then it goes back down. But let's say I didn't cut off my arm. Let's say I just hammered my thumb, okay? My blood pressure is going to go up. My heart rate's going to go up. My respiratory rate is going to go up, okay? All of that is going to happen, okay? When you throw your back out and you have that intense, really, really fast pain that happens immediately. When you pull a muscle, okay? All of those acute pain, your vitals change, okay? We don't see that necessarily with chronic pain, okay? Because your body has adjusted the physiologic responses. They're no longer active in somebody with chronic pain at that point. All right, neuropathic pain is a type of chronic pain. And neuropathic pain is interesting because here the pain gets worse, but there's nothing stimulating it. Okay, and it's caused by lesions on the nerves. So peripheral neuropathic pain is very commonly caused by diabetes. And when we have peripheral neuropathic pain, or peripheral neuropathy, our patients will complain of numbness and tingling, burning sensations that are shooting up their legs. That's neuropathic pain. Okay, it's not the kind of pain that they stepped on something and that's why their foot hurts. Okay, so it's lesions on the nerves. Now, central neuropathic pain is caused by a lesion or a dysfunction in the brain or spinal cord as opposed to the peripheral nerves. Okay, so peripheral neuropathic pain is often diabetic neuropathy. Central neuropathic pain is if you've got something wrong with your spinal cord. Either way, you've got neuropathy. Okay, so we've talked about neuropathy. All right. One more type of pain that I want to mention as a subset of chronic pain. So neuropathic pain is one kind, so is cancer pain. Cancer pain is caused by many things, including the pressure of tumors pushing on organs and other body parts, okay? So cancer pain is a type of chronic pain. Now let's move on and let's talk about temperature regulation. So our temperature, our body temperature is mediated by the hypothalamus and the endocrine system. And we have thermoreceptors in our skin. We have them in our liver. We have them in our muscles. We have them in our brain, our hypothalamus, okay, the spinal cord. All of those are places where we have thermoreceptors. And our temperature regulation varies a lot, okay? Depends on the person, depends on where you are. Are you male or female? What are you doing? Where are you? You know, all of those things affect temperature regulation, okay? How do we produce heat in our bodies? Just our chemical reactions. Metabolism creates heat. It produces heat in our body. Our muscle tone, muscle contraction, those produce heat, okay? How do we keep our bodies warm? That's through heat conservation. Well, we shiver, right? We shiver, and those are muscle contractions, and those increase the heat. Or our blood vessels, we will vasoconstrict, bring everything closer to the body. Just like if we want to cool ourselves off, we vasodilate, and with more blood in the periphery, it cools off because of the location to the environment. Obviously, we have voluntary mechanisms that you do to conserve heat, like putting on more clothes, you know. Now, when we talk about, here we go. Temperature regulation in infants and elderly. So I do have a slide about that. When we have, the very young and the very old can't regulate their temperature as well, okay? And so with these, they produce the body heat. So infants produce body heat. They can't conserve it, though. Their bodies are so small, and they have a really high body surface to weight ratio, and then they have a really thin subcutaneous layer, okay? And so all of that means they can't conserve their heat. And so you've got to make sure you keep them warm. Now, the elderly also have issues regulating their temperature because their blood it just doesn't circulate as fast, okay? They're slower to vasoconstrict, to conserve their heat. They have an overall decreased metabolic rate, which means they don't make as much heat, okay? And they don't sweat as much. They don't shiver as easily to conserve heat. Decreased sweating means they can't lose their heat as much if they need to cool down. And they also have an altered perception of heat and cold. And so all of those play in when we're talking about the very old and the very young with temperature regulation. All right, so heat loss, there's many ways to lose heat. Radiation is so that's directly touching something, right? So if you have something, if a body part is warm and you touch something that is cold, then that's radiation. Okay, the heat goes into the cold item. Conduction. That's conduction. Radiation is through like the sun. Okay. Convection is the process of losing heat through the movement of air. Okay, so a fan. Convection is a fan. The amount of heat loss depends on how fast the fan's going, right? Vasodilation and vasoconstriction are a way that we can lose and gain heat. If we vasodilate, it will cool off our blood because more of it's at the surface and exposed to fairly close to the environment. Okay. muscle tone affects our heat loss. People with more muscle mass are less susceptible to heat loss. That's one of the things with the elderly. They will heat up faster after cold exposure than people who don't have a lot of muscle mass. And so remember, our muscles generate heat, okay, to keep the rest of the body warm. Evaporation is when something's wet, so that's going to be sweat. Increased respirations. A lot of that is also, so you're breathing out hot air, okay? Voluntary measures, talked about that. Putting on or taking off clothing. And then people really do eventually adapt to hot climates or warmer climates after a few weeks. And how they do that is that the blood concentrations of water and salt adjust to allow the to allow greater cooling, and then the blood vessels actually change to get more, more. So you're going to have a constant vasodilation, for example. A lot of athletes do this and train in harsher climates to cause these body adaptations. All right, so now let's talk about fever. So a fever is where you reset the thermostat in the hypothalamus, okay? So remember that your hypothalamus is what regulates your thermostat. A fever resets it, and so it changes our set point, okay? Now, different things can cause fevers, including exogenous pyrogens, like, for example, bacteria, okay? Endogenous pyrogens also. So these are substances that are usually part of the inflammatory process, and they induce fever by acting on the hypothalamus. So some examples there are tumor necrosis factor, interferon. Those are endogenous pyrogens that are released as part of the inflammatory process in order to reset our hypothalamus to give us a fever, okay? Now, a fever of unknown origin, just to mention this, your fever of unknown origin is something where you've got a fever for a few days. We can't figure out why, okay? We cannot find an infection, okay? We cannot find a source of an inflammation, okay? And usually if somebody comes in with a fever, we don't have that hard of a time pinpointing where the infection is coming from, okay? We just culture everything, and we can typically find it. All right, so what does fever do? Well, it kills microbes, okay? And so that's a really positive thing. It decreases our levels of iron and zinc and copper, not such a positive thing, okay? It promotes lysosomal breakdown and autodestruction of cells. Maybe that's good, maybe that's bad. It depends, okay? It does increase our lymphocytes, our lymphocyte actions, and also their abilities to phagocytize. And so we want that, right? Because we want all of the foreign organisms to get destroyed. It also helps you produce interferon, which fights against viruses. So fever is a really good thing when you've got an infection. Hyperthermia, on the other hand, is different. So hyperthermia is when your body temperature goes up, but the hypothalamus doesn't change its set point, okay? And this is a problem because your set point is what keeps you from getting too high, okay? Hyperthermia can produce nerve damage. It can cause your cell proteins to coagulate, which then causes them to die. Hyperthermia will cause death, okay? Now, hyperthermia can be therapeutic. It can be accidental, or it can be a result of a stroke or head trauma that has damaged our thermal regulatory center in our brain, okay? We call that a central fever. Now, therapeutic hyperthermia, this is actually like local or regional heat that is used to destroy usually cancer. So we use it sometimes alone, but usually in combination with chemo and radiation therapy, or both. And it does work. It works really well. It basically just cooks the cancer and kills it. So let's see. The central fever that I was going to talk about. So when you have CNS trauma, so that was your therapeutic hyperthermia. Um, if you have a stroke or head trauma, that central fever, that's as a result of increased ICP or maybe intracranial bleeding. You don't sweat with it. Okay. Now with traditional hyperthermia, you will, and we're going to talk about different types of hyperthermia. And central fever doesn't respond to stuff like Tylenol. Okay. It doesn't bring your fever down. Accidental hyperthermia, that would be things like if you've got some kind of burn, if you like a large scale burn, things like that. That could be like if you were in a hot tub and you burned or something like that and you didn't get out. So that would be an accidental hyperthermia. All right, so as we go through hyperthermia, we're going to start at the beginning here. Heat cramps, okay? So heat cramps are cramps that you get in your stomach and your extremities, and this is the first stage when you're exposed to the heat for a long period of time. So if you go to Florida or the Bahamas or something like that, and you're not used to heat and you start working out like you usually do, you go and you run 3 miles, okay, or more. And you're doing strenuous activity. This is really common. And what happens is you sweat a lot, right? And you lose a ton of sodium, and that's what causes the cramping, okay? Now, you will also sometimes have increased blood pressure and a high pulse as a result. And this is your body kind of trying to regulate things, okay? What you need is water and salt, okay? When you're super, super dehydrated, remember, you don't want to just have water. You want to have something with electrolytes in it, something with sodium in it, okay? But they need fluids, they need rehydration, and they need salt. If they don't get it, okay, then we move into heat exhaustion. At this point, now we've got a lot of sweating, okay, and which has caused our dehydration. But we've lost so much fluid now that we have a decreased volume of blood, okay? So the amount of plasma in our blood vessels is down because remember, the plasma is the water portion of blood. And so because of that, now we've got hypotension. Our heart's not working as well because it doesn't have any blood to pump, okay? And so our heart rate jacks up to try to make up for that, to increase the blood pressure, to increase our cardiac output, okay? At this point, you're going to become dizzy, weak, nauseous. You may start to have some mental status changes. People here will pass out from heat exhaustion, okay, because their blood pressure is so low that they can't maintain consciousness, okay? Now, we're getting into the danger zone here. And then heat stroke now. This is where your thermoregulatory center, it can't handle it anymore, okay? Your brain cannot tolerate a temperature above 104. Now, this is different in kids. Kids are very... they can rebound back very easily, okay? Now, if you're an adult and you have a body temperature over 104 for longer than a brief period of time, then we have an issue. Your hypothalamus, your central structures in your brain, your respiratory center, your cardiovascular center, they won't work anymore, okay? So we are talking about brain death here with heat stroke. Complications then. So cerebral edema, degeneration of the CNS, swollen dendrites, all of those are going to happen just like I talked about, where and those are going to affect your circulatory center, your respiratory center, your brain. The other things that it causes, because now you've got degeneration of the CNS, and you've got the auto-regulation of our body is not working right, okay? So now we've got renal failure, we've got hepatic failure, and most of these patients will die because, and again, they're going to die of either cardiac arrest or respiratory failure because their brain can't do it anymore. Okay, because you've destroyed those centers with that heat. Hypothermia now, on the other hand, this is a body temperature less than 35 Celsius. When you have hypothermia, what happens is that the reason it's bad is that ice crystals actually form in your cells. And now if you've got ice formed in your cells, they're going to die, okay? So what happens then is throughout the tissues, you've got death of tissues, okay? So tissue hypothermia, for example, frostbite, okay? Those cells that have ruptured and died, they don't recreate, okay? They don't regenerate. And so one of the things that we have, sorry, I'm getting emails that are popping up on my screen. I apologize for that. One of the things that hypothermia is good for, though, is that it also protects the body, okay, specifically the brain. When you are hypothermic, it doesn't need as much oxygen, okay? So we call that therapeutic hypothermia. And we do that on purpose to preserve tissue. Now, we do therapeutic hypothermia if someone cardiac arrests, okay? We do therapeutic hypothermia to preserve brain tissue, okay? So that we can get the heart restarted. Now, hypothermia in general can also lead to that, okay? And so if you have somebody who has a massive MI, for example, we will sometimes do therapeutic hypothermia to get that heart, to give us time to fix the heart so that we don't destroy the brain, okay? But too much time hypothermic can damage the heart as well, and that can lead to VFib, cardiac arrest. We also do therapeutic hypothermia if we cut off like a thumb or a finger or a hand. Okay, and that preserves the tissue until we can get circulation restored. Now, accidental hypothermia, and this is actually why we started doing therapeutic hypothermia, but when people fell into like frozen lakes, we pulled them out and they looked dead, right? But after we warmed them up, suddenly they were fine. And we're like, you weren't breathing. How did you survive? Well, it was that the hypothermia reduced their oxygen needs to so low that they survived, okay? And so that's why we were like, it works for people when they fall into a frozen pond. Maybe it'll work in a hospital. And so that's how we figured out therapeutic hypothermia. All right, now let's move on to sleep. So there's there are two basic phases of sleep. Okay, you got your REM sleep and your non-REM sleep, but sleep is sleep has many phases, okay? Because you've got your falling asleep, and then you've got your deep or your light non-REM sleep, and then you got your deep non-REM sleep, and then you got your REM sleep, okay? Our hypothalamus is also our sleep center. The hypothalamus is really important, okay? So the hypothalamus is what promotes your stages of being awake and your stages of being asleep. So mess up your hypothalamus, and you're going to have a problem with sleep. Now, I'm going to start with REM sleep. Your labels may be incorrect on here. I can't. I had cut and pasted the wrong thing. REM sleep, we're going to start with REM sleep. That's about only 20-25% of the time. And it occurs about every hour and a half, 2 hours. Okay. And you'll have, you have your non-REM sleep, and then you have some REM sleep, and then you have some non-REM sleep, and then you have some REM sleep. Okay. And REM sleep is interesting because when they do EEGs and look at your brain waves, it actually looks similar to being awake. And so you have muscle relaxation. usually you are paralyzed. Okay, so it's sleep paralysis in your REM sleep. Okay, non-REM sleep, on the other hand, this is most of the time, right? 75 to 80% of the time. And at this point, you have, instead of that rapid eye movement or changes in heart rate and stuff that we see in REM sleep, now we have a decrease in heart rate, a decrease in temperature, a decrease in respiration and blood pressure. Everything goes down in your non-REM sleep. Sleep disorders are characterized by when they occur and what the issue is. Okay, so dysomnias are an alteration in your sleep pattern itself. Okay, parasomnias are things that occur while you sleep. You can also have a sleep disorder that's associated with medical or psychiatric disorders. And then there's some sleep-related movement disorders also. Your sleepwalking is not a movement disorder, okay? But some people have different types of movement disorders. So we'll talk about these, okay? In general, when we're talking about insomnia, we're talking about the inability to fall asleep or the inability to stay asleep. Okay. Oh, I forgot to switch slides. Here we go. So this can be transient or it can be chronic. We've all experienced some transient insomnia here or there. Okay. When it becomes chronic, now we're looking for how can we fix it? Okay. How do we fix this insomnia? And a lot of people will go to medications that will cause drowsiness. Some people will look at sleep habits. Okay, so there's lots of different things there. Sleep apnea or obstructive sleep apnea syndrome, OSA or OSAS. So this is our most commonly diagnosed sleep disorder. Risk factors include obesity, being a male, being older, being postmenopausal if you're female. And it results from total or partial upper airway obstruction or collapse. Causes excessive snoring. It causes gasping. And you will have multiple apneic episodes that last longer than 10 seconds. This disrupts the total sleep time and it produces hypercapnia. So hypercapnia, remember, is high levels of carbon dioxide and also low oxygen saturations, low O2 sats. If untreated because of the low O2 sats, you get pulmonary hypertension because hypoxia causes your pulmonary vasculature to vasoconstrict. Your bone marrow, you start producing more red blood cells because when you have hypoxia to the kidneys, they produce more erythropoietin, and that then stimulates the bone marrow to make more red blood cells. This is why patients with COPD have polycythemia, which is the excess amount of red blood cells. People with sleep apnea also have this, though. It can cause heart failure. It can cause dysrhythmias. Lots of long-term problems with this. Okay. Obesity hypoventilation syndrome is usually so if you have somebody who has obesity hypoventilation syndrome, they probably have sleep apnea. It's a combination of obesity, daytime hypercapnia, okay, so high levels of CO2 in the blood, and then some kind of sleep disordered breathing, okay? Now, it's because the abdomen pushes up on the lungs, and so they don't get a very deep breath when they're lying down, okay? And so the really large kind of beer bellies that you see in some guys, they'll go up, and then they can't expand their lungs fully. That's what causes that obesity hypoventilation syndrome. Hypersomnia This is a side effect, if you will, of sleep apnea, and this is excessive daytime sleepiness, okay? It's falling asleep during your activities. It causes problems with your mood. It causes problems with your thinking because you're not getting good sleep at night, okay? So we do a sleep study. They're called we call them sleep studies. It's polysomnography, and they literally hook you up and watch you sleep. Okay, they figure out, okay, are you still breathing? Treatment for it, CPAPs. Okay, so this guy's got a CPAP on, and what it's doing is it's continuously blowing air so that airway doesn't collapse. All right, circadian rhythm sleep disorders. Common causes of these, extrinsic causes, if you will, rather than intrinsic causes, because there are some people who just have, bad sleep. But here we've got problems with that 24-hour cycle that we have that is your circadian rhythm, okay? So things that can cause it include a rapid change in time zone, okay? Otherwise known as jet lag, okay? An alternating sleep schedule, like if you work an alternating night and day schedule. So when you rotate shifts, it's really hard on your sleep schedule. So it's better if you rotate to do a whole bunch of night shifts and then switch and do a whole bunch of day shifts to do a longer rotation. Changes in your total amount of sleep will really disrupt you, okay? Then we have some intrinsic causes. So, for example, advanced sleep phase disorder or advanced phase sleep disorder syndrome is a disruption of your circadian rhythm, which makes them go to sleep earlier than normal and wake up earlier than normal. So these are the people that just can't handle staying up late. And when I say earlier than normal, I mean like what has dictated what is good for their life. Okay. So maybe they're going to bed at like 4:00 or something like that. And this can have long-term health consequences as well. Delayed sleep phase disorder or delayed sleep phase syndrome is a disorder where your sleep is delayed by 2 hours or more beyond what's considered an acceptable or conventional bedtime. And that causes difficulty in being able to wake up at the desired time. And so there's a lot of people who have this. And so we actually look at it. The treatment for it is really very simple, and that is you just make yourself go to bed earlier. So every night you go to bed 15 minutes earlier, and you look at your sleep hygiene habits, okay? So you stop playing games in bed, you stop reading in bed, things like that. And so the other thing that helps with that is bright lights in the morning to help you wake up. Maybe something like melatonin to help you go to sleep earlier. So all of these circadian rhythm disorders, they can affect you long term. So they, in the short term, it affects memory and concentration. Long term, though, your circadian rhythm has been found to have an impact on cardiovascular status, on weight control, on digestion, on your immune system. So sleep disorders can affect all of that. All right, parasomnia. So these are during our non-REM sleep, sleepwalking, night terrors, rearranging furniture. People eat when they're asleep. People have sleep sex. Some people become violent. Some people become restless. So this is manifested by the loss of that paralysis that you typically have, and then all of a sudden we start moving. Okay, so with all of these parasomnias, a lot of times the fix will, if you will, is just to maintain better sleep hygiene. And obviously violent behavior is different, and that has to be looked into. Violent behavior during sleep, that particular parasomnia, And actually, so are some of the other ones, but it can be an indication of a psychiatric disorder, sometimes PTSD, for example. So we look into those, okay? They can also be medication induced. So some of our parasomnias, including sleep eating, can be caused by sedatives. And so, for example, Ambien, one of the very popular sedatives to help you fall asleep, causes sleep eating. And so that was, it's one of its known side effects. All right, couple review questions and we'll finish here. 15-year-old male hits his finger while hammering a nail. Which of the following best describes the pain he would feel? Pause and answer that to yourself. That is B, somatic pain. So that's your superficial pain coming from the skin, close to the surface of the body. Okay, that's your somatic pain. All right, which part of the brain is responsible for temperature regulation? That is D, hypothalamus. All right, that is the end of this video.